Today we're going to talk about white blood disorders. In white blood disorders, I have created some schematics. We will look at some proliferative disorders right here. These are divided into myeloid and lymphoid. And under myeloid, we have chronic myeloid leukemia, polycythemia vera, and thrombocythemia. And in lymphoid, we have multiple myeloma and Waldenström myeloma. And if there is, anything related to marrow failure, we have aplastic anemia and myelodysplasia or myelodysplastic syndrome. And if we talk about malignancies, other malignancies, we have lymphomas, leukemias, and myelomas. In lymphomas, we have a solid mass, while leukemia is liquid, like blood, there is no mass. And of course, myelomas. And then we have benign leukocytic reactions, qualitative and quantitative. Quantitative is such as eosinophilia, basophilia, neutrophilia, etc. And then qualitative, we have the leukemoid reaction, etc. Now, here you need to know that in marrow failure, it is going to decrease the amount of blood cells, all kinds, are going to decrease in aplastic anemia. But in myelodysplasia, it is going to, the bone marrow is going to be hypercellular, but all the cells, they actually do not work. They're functionally incompetent. When we talk about the proliferative disorders, in myeloid cells, all the myeloid cells are going to increase, and in lymphoid cells are increased. This essentially tells all blood cells will increase in number, and both are, of course, neoplastic or cancerous. And in hematological malignancies, we only talk about white blood cells. Okay, so in these myelomas, only the WBCs will increase, and then we are going to consider this in this category. Okay, so here is our normal hematopoiesis. You're going to be seeing this particular picture quite a lot. So under this, we need to talk about two terms. One is called as leukopenia, and the other is called as leukocytosis. So leukopenia is basically decrease in the amount of WBCs, and leukocytosis is increase in the amount of WBCs, all kinds. So of course, leukopenia has two types. We have neutropenia and lymphopenia. Neutropenia is when neutrophils are decreased, and lymphopenia is when lymphocytes are decreased. The causes for neutropenia includes drug toxicity. It could be alkylating agents because they damage stem cells, and it could be severe infections. And for lymphopenia, there could be any kind of immunodeficiency syndrome in a high cortisol state. In high cortisol state, basically, apoptosis is induced. Apoptosis of lymphocytes are induced. And there could be autoimmunity, any kind, for example, SLE. And of course, ionizing radiations, but this is mostly with whole body radiation. Okay. Then for leukocytosis, we have types. Neutrophilic leukocytosis, it could be in bacterial infection or high cortisol state. And monocytosis in chronic inflammation and malignancy. Eosinophilia in allergy, parasitic infections, or Hodgkin's lymphoma. Basophilia in CML. Lymphocytic leukocytosis, or we can also call it infectious mononucleosis in infections or EBV. I'm going to detail it right now. But before that, if we go back here, right now we are only talking about WBCs. We've already done red blood cells. So here is the red blood cell. Erythrocyte precursor is the red. It is going to form the red blood cells. And so when you have decreased the amount of RBCs, it is called as anemia. And when it's increased the amount of RBCs, we call it polycythemia, right? Same case with platelets. We've already done platelets. If you decrease it, it's called as thrombocytopenia, right? Same case with leukocytes. If you increase, it's called leukopenia. If you decrease, it's called as lymphocytosis. Now we are going to do, okay, for infectious mononucleosis. For infectious mononucleosis, we need to know that it is associated with EBV. It is associated with EBV infection, all right, and the EBV infection that results in lymphocytic leukocytosis. So EBV is, transmitted by saliva, and that is why this disease is also called as kissing disease. Right. So what it is going to infect then, of course, oropharynx, because it is transmitted by saliva. It can also affect liver and, of course, B cells. Now, because this leukocytosis is going to increase reactive CD8 cells, CD8 T cells, because of this, it is going to cause generalized lymphoadenopathy, and because of T cell hyperplasia in the lymph nodes paracortex, right? And it is also going to cause splenomegaly, and that is in the PALS. PALS is basically periarterial lymphatic sheath. They're the part of the spleen. There it is going to cause splenomegaly because of that. And of course, we're going to have WBC count. That is a no-brainer. Now, for confirming or for, telling that, okay, or diagnosing this disease, we do a monospot test. And the monospot test is going to detect IgM antibodies, and that is going to cross-react because, how they actually detect it, because these IgM bodies, they're going to cross-react with the sheep or horse blood cells in the medium. These are present in the medium. And if there is a negative monospot test, if this is negative, then it could say that it is a CMV rather than a IM. And of course, a definitive diagnosis. For a definitive diagnosis, we need to do serology. And that is it for today.